begins as these surface implants that you cannot see or feel. So the imaging would be normal, the exam would be normal, and yet you could have surface endo and have that cut out and feel better and have improved fertility. Women are being told, your ultrasound is normal, your imaging is normal, your exam is normal, you can't have endo. That is absolutely not true. We do know that treating endo, removing the implants or treating the disease well, improves pain, quality of life, sexual functioning, and improves fertility.
Welcome back to the Truth and Fertility Podcast. I am Haley Yeager. Today, I am chatting with Dr. Patrick Yeung. He is a surgeon who specializes in endometriosis removal, but not just any endometriosis removal. He has founded a very specialized way to remove endometriosis to relieve women from either pain during their periods or even infertility. And this is what he does all day, every day. And so I'm very excited to pick his brain about his specialized way in which he helps women with endometriosis and specifically removing it and surgically. So Dr. Patrick Yeung, thank you so much for being on the show today.
Thank you so much for having me on and for the opportunity.
Thank you. So if you can go ahead, Dr. Yeung, introduce yourself, anything you'd like to tell the audience. And then I'm also really curious to know, I know you have some sort of personal story that really drives your passion to wanting to help women with endometriosis. So maybe if you could share a little bit about that too.
Well, and my hope and prayer really is that, through this chat, this discussion, something resonates with somebody and there's some good information for someone. So I was in academics for most of my career. We published a few important papers. I began Restore Center for Endometriosis to pay it forward first and foremost. And we'll talk a little bit about that, but to also enter the conversation among centers of endo. So as a center dedicated to treating endo, I like to say that we are the only center that does not rely on post-operative suppression or Band-Aid therapy to suppress what we don't get or to prevent from growing what we don't get or coming back. And that does not rely on or refer to IVF. We don't offer it, we don't refer to it. So that really makes us very unique in that our focus is really, we call it a root cause treatment to remove the disease instead of what I call Band-Aid or bypass therapy. So that's what we're about. And we've shown in kind of what I would say is our landmark publication, a 10-year study from St. Louis University, a very low rate of repeat surgery and the potential for one and done surgery. And we'll talk more about that. But in our story, I like to say my wife had painful periods her whole life, thought it was normal, maybe like most people. When we got married, we tried to get pregnant from day one. After about a year, my wife said, maybe I have endometriosis. I said, no way. She had bad endo. She had one surgery to remove the endo and then multiple surgeries to prevent adhesions where things can stick after surgery. She was really prone to adhesions. We call that kind of a person an adhesion former. She's now pain-free. We've had recurring fertility. We're really here to pay it forward. That's what we're all about.
That's amazing. Now, before we get into your specific surgical practice and how you maybe do surgery differently than most endometriosis removal surgeons, can you explain what endometriosis is, just for the listener that doesn't quite know?
Yeah, so it's cells in the wrong place. So it's where the cells which line the uterus and are shed during the period, those cells are found outside the uterus, implanted on the peritoneum, or I call it the wallpaper of the pelvis. Even though it's by definition outside the uterus, the number one symptom is pain with periods, and that's the number one symptom to improve. How does that work? We don't really know. It begins as these surface implants that you cannot see or feel. So the imaging would be normal, the exam would be normal, And yet you could have surface endo and have that cut out and feel better and have improved fertility. So women are being told your ultrasound is normal, your imaging is normal, your exam is normal, you can't have endo. That is absolutely not true. And it's well documented that the amount of a disease and the amount of symptoms do not line up well. In fact, how does surface implants, which aren't deep enough to be in the nerves, cause pain, or without distorting tubes and ovaries, cause infertility, which are the two main symptoms, so to speak, of endo, is a great question. We don't fully understand that. But we do know that treating endo, removing the implants or treating the disease well, improves pain, quality of life, sexual functioning, and improves fertility by at least double. A recent study showed 4 times improved pregnancy rates.
Wow.
So we know that surgery helps. Maybe the why or the complete understanding of how is less important. But it's a very common disease. So I like to say there's a TED talk called The Most Common Disease You've Never Heard of. I love that title. And that's endometriosis. Everybody knows somebody with endo. I like to make the point, that there's this kind of campaign almost out there, hashtag 1 in 10, as if that rate is very high and deserves attention. That is maybe true in the entire female population, most of whom have no symptom. But if you have infertility and no pain, it's at least 50% chance of having endometriosis. If you have pain that does not feel better when taking hormonal suppression for that pain, your chance of endo is over 80%. And
Wow.
from our 10-year study at St. Louis University, if a patient had both significant pain and infertility, the chance of having endo was over 90%. It was 93%, heading towards 95%.
Wow.
And most of those patients are told they have unexplained infertility.
Well, because you said it's something they're not able to see on imaging, correct?
Correct.
Okay. When you
Well,
decide
when it's early stage,
when
we
it's
do
early
imaging and an
stage.
exam, very important to look for deep disease to plan for surgery,
Okay.
which you can see or feel on imaging or exam. But a negative exam does not rule out surface endo, and surface endo can cause a lot of pain and affect fertility. Yes.
So are you saying that severe endometriosis is something that can be seen on imaging? Is that what you're
Correct.
saying?
Advanced
Okay.
endo, when it's gone beyond the surface and is either a ball of it in the ovary called an endometrioma, or has developed some thickness to it, some depth to it, and is a nodule in the bowel, we can see that or feel that. So we ask patients kind of for what's called a surgical planning visit to do a what is now standard among centers of endo, mapping ultrasound to look for evidence of deep disease to plan for surgery. It doesn't rule, if it's all normal, it in no way rules out surface disease, and you can have surface endo that can lead to significant symptoms of pain and infertility, even without being able to be seen or felt, because it's just on the surface. But we look for deep disease to plan for surgery. When we started Restore Center for Endometriosis in July of 2024, consensus guidelines came out to use ultrasound for what's called disease mapping, to map out the disease, again, to plan for surgery. So we're following these guidelines, and we use ultrasound to not just look for cysts, which is the usual purpose or finding on ultrasound, a transvaginal ultrasound. It's to look for nodules in the bowel. So we're looking backwards behind the uterus for nodules in the bowel. So this is, again, very specialized ultrasound. Our sonographer is great. She's had over 20 years of GYN only experience and still underwent a year of training just to look for these bowel nodules. And it's to a point now where it's almost for sure. No, nobody's perfect, but That if she says there's a nodule, there's a nodule. If she says there's not a nodule, there's not a nodule. And that really helps us plan for surgery. So the in-person surgical planning visit is not to rule out endo, it's to plan for surgery.
Okay. When you say a nodule, is a nodule endometriosis? Is that what you're saying? Or what would the difference be? And how would
Yes.
it indicate?
It's endometriosis
Okay.
that has gone beyond the surface, has some depth to it, is a mass
see.
or a nodule of it that you can see by imaging.
So if you do that imaging, you said, of course, the imaging doesn't rule out the surgery necessarily. If a woman undergoes that surgery or that the imaging at your center, and let's say comes back and everything looks okay, are you are still going to plan for that surgery as long as the patient is willing? Okay.
So I always say, by talking to a patient, we can give you the chance for your chance of having endometriosis. 50, 80, 95%. That's your chance just by talking to you. The surgical planning visit is to determine how much endo you have, which I cannot know by talking to you. So we can plan for surgery. Because it's well documented that the amount of disease and the amount of symptoms do not line up. You could have a little bit of endo and a whole lot of pain, or a lot of endo and no pain. Just because you have advanced pain or stage 4 pain, so to speak, you're missing schoolwork, can't function, it doesn't mean you have advanced endo or stage 4 endo. If that makes sense.
It does. I'm curious, and I don't know if this is known by science yet, but why is that? Why is it that someone could have a lot of endometriosis and little to no pain, or even the opposite?
That's a great question. How are these surface implants that aren't deep enough to be in the nerves causing pain? There's different theories for that. Toxins, inflammation, inflammatory markers, lots of, centralization of the pain, where the brain is processing pain differently over time. There's lots of different theories about that. Again, we just know that that treating endo helps both pain, quality of life, sexual functioning, and fertility significant. And our goal as a center of endo is to plan for the right surgery. These people that teach this mapping ultrasound have said that, the science or the imaging is so good, it's to the point where you should never be surprised. You should know what you're getting into so you can plan for the right surgery, the right amount of time for surgery, the people you need there to complete that surgery, to give you the best chance of one and done surgery. Which, again, is never a guarantee, but we're striving for that. And we're showing that it matters who's doing the surgery, the planning that goes into that surgery, what the surgical goal and result is of the surgery for best outcomes. I've been saying it's not how much endo you have going into surgery that matters, or more importantly, that is predictive of your outcome, of how you will do for pain and fertility. It's how much endo you have at the end of the surgery that matters. And we'll talk about the way, most people treat endometriosis, but they're probably not getting it all. And that's why the outcomes, the rates of repeat surgery are not as good, and the rate of repeat surgery is so high because they're not removing it all.
That's exactly what I wanted to ask you next, because you claim a one and done surgery, which is not most women's experience when they go in to have endometriosis removed. So what is the kind of maybe the mainstream way that surgeons will remove endometriosis, and how does that differ from the way that you practice surgery in removing endometriosis?
Yeah, so we got this paper published, but I will admit it was very challenging. because it's so unbelievable. It's against the narrative, and no one, I mean, we showed an under 5% rate of repeat surgery in 10 years, as opposed to what is published after the way most people treat endo, which is a rate of repeat surgery of up to 80% in 2 years. Ours was under 5% in 10 years, and most of our patients took no long-term suppression post-op. We told them if we felt like we removed it all or achieved our goal of optimal excision, which is basically no known or suspected endo left behind in any location, even on or near vital structures, then they didn't have to take the post-operative suppression. And most did not, because they were either trying to get pregnant or didn't like the side effects. It's a very different surgical mindset, I say, to say, I'm just going to treat some endo, but whatever I don't get, I'm going to put patients on suppression that should suppress what I don't get. That's what everybody recommends. And so I don't have to remove it all. And this spot here near the ureter, we'll leave that. The suppression will take care of that. Versus trying to remove it all to specifically not require suppression post-op. We're trying, theoretically, there should be nothing left to have to suppress. That is a very different surgical mindset, and I think we've shown a very different surgical result.
Yeah. Just to be clear, too, when you say hormonal suppression, are you saying that the typical way that surgeons would treat endometriosis is getting most of it, but not all, and then putting a woman on hormonal birth control after? Is that what you're saying is the
usual thinking is you need to be on suppression, okay? And when I say suppression, there's two forms of suppression. Medications that induce a state of chemical pregnancy, like birth control pill. Or now the newer FDA-approved medications for endo pain are really inducing a state of chemical menopause. Really chemical castration. Why do I say that? For dramatic effect. But the newer FDA-approved medications are really oral forms of Lupron. And Lupron is used in men with prostate cancer. Lupron is used as a puberty blocker. And now they're giving this same kind of drug, same class of drug in pill form to young women and saying, this is great for your endo pain. But they don't tell you what it's actually doing. You can have serious side effects, the least of which are menopause, like going crazy. There's a Lupron Victims Awareness Hub online. 20,000 women talk about their serious side effects with Lupron, like going crazy. And I think it's just a matter of time before we see that with these newer medications, because it's the same kind of drug. So at best, it's Band-Aid therapy. At best, you feel better with one of the two forms of hormonal suppression. But they're saying you need to be on suppression until surgery to keep it from growing, and after surgery to keep it from coming back. Neither have been proven. And again, in our data, we showed a very low rate of repeat surgery, even when the majority of our patients did not take long-term suppression post-op.
I'm even imagining the woman that's going into this surgery for infertility. Why would she want to be taking hormonal suppression?
You can't anyway. Yeah.
I mean, that doesn't make any sense to me. So you said earlier that comparing the way that you practice surgery to other surgeons, if you're seeing endometriosis, maybe even stage 4 endometriosis on a vital organ, other surgeons might not want to touch that, but you are removing that. Is there a specific way that you're removing it as to not damage that vital organ or any part of the woman's body that you're seeing endometriosis on?
So the way most people treat endometriosis is called ablation. There are different words for the same concept: ablation, cauterization, coagulation, fulguration, even laser vaporization. It's the same idea. You're trying to destroy the implant with energy, but nothing is removed from the body. The categorical difference with excision, which is what we're doing, which is to cut it out, is that we always produce a specimen. There's something that is removed to then be sent off to pathology for a tissue diagnosis, which is the gold standard. The gold standard diagnosis of endo is not visual. It's a tissue diagnosis. But by making you cut something out, you can make sure you get it all out. If it's widespread surface, so it starts off on the surface, we talked about that, right? And it can be a whole patch of it sometimes. To just even laser vaporize it, let's say, it's like trying to paint the wall with a pencil tip. It's a lot more complete and cleaner to just cut around the whole patch and remove the patch. Or if it goes deeper, again, as it is more advanced, it can go deeper. You're literally trying the tip of the iceberg if you try to just ablate it. And that can bury it and make it worse. Patients have gotten up after ablation surgery and said the pain is worse. So we're going to cut under the roots. So again, cutting around it and under it to produce that specimen to be sent off to pathology not only ensures that we get it all, but we get that tissue diagnosis. If you just burn it, you're not getting it all, and you don't know what you just burned. So when they say the rates of repeat surgery are up to 80% in 2 years, they're probably looking back, seeing endo again, saying that the disease has come back. But more than likely, what is really happening is they're seeing the same disease from before that was either not treated or partially treated. If you think about it, they're really seeing the same disease over and over again. So unfortunately, that is the status quo. That is the norm. That's the usual thinking. Just expect it every 2 years. And I tell patients all the time, they could have had the surgery that we do could be their 5th, 6th, multiple surgeries often. Surgery. And yet it's the first time they actually ever had it removed.
Wow.
Which is sad to say.
Yeah. Yeah.
So again, our data is showing several things. Again, there's no guarantees. I never guarantee somebody cannot need to have surgery again. Nobody's perfect. There is no cure technically. But our data is showing several things. Number one and done surgery is possible. It was a 10-year study. There's very little long-term data. And so we tried to do that. And again, we showed a very low rate of repeat surgery in 10 years. So one and done surgery can be for many patients, if not most patients, and without relying on postoperative suppression. And again, I think the implication is showing that we should be striving for one and done surgery, and the surgeon matters, and the surgical goal matters, again, to try to remove it all, to have nothing left to have to suppress matters, and affects and is reflected in our outcomes. And then the last piece is, strongly believe the way to get to the hope of one and done surgery is not even just remove it all. We call this optimal excision, defined as cutting out whatever is suspicious for endo in whatever form and wherever found. Again, we'll cut it out even your vital structures, bowel, bladder, vessels, nerves, ureter, fallopian tube, are all areas we would treat where others would not. So very few can achieve optimal excision already, but even if you can achieve optimal excision, that's still not enough. You then have to prevent adhesion. That's the other half. That's where things can stick after surgery. Even fewer do that well. And again, that was very important in our surgery. So my wife, in our story, my wife had 1 surgery for endo and then 5 surgeries for adhesion. We're trying to avoid the need for that. And so we have different things to really be deliberate about preventing adhesions. So there are some people that are really good at cutting it out, but then don't prevent adhesions. Other people are really focused on preventing adhesions, but don't remove all the disease. They're afraid to promote adhesions. I have always thought, and I think our data is showing, that one should not compromise the other. They're 2 separate issues and both need to be done well. Do whatever it takes to cut out all the endo, and then do whatever it takes to prevent adhesions. And I think that's how we're showing such good outcomes.
So how do you prevent adhesions? What do you do during surgery to, as you said, this is the second half really of the
Yes.
surgery and how important that is. So what does that look like?
So different things. So for example, if the first kind of the more common form of advanced endo that's gone beyond the surface is you get a ball of it in the ovary called an endometrioma or chocolate cyst, which is really a surgical term. You don't see chocolate on ultrasound. When you rupture it, out comes chocolate. That's pathognomonic or almost always an endometrioma. So that it's been shown to cut out the cyst is better than just draining it. We just reaccumulate. So we cut out the cyst wall, which has been shown to be better for reducing pain, reducing recurrence of that cyst, and natural fertility. Even if cutting out the cyst can lower AMH, which is worse for IVF success, cutting out the cyst is better for natural fertility. So we do that. But then people will leave the ovary open. The ovary is now kind of clamshelled open after you cut out the cyst wall, and people will leave it open. We're taught you don't have to close it. We would never do that. We would suture it closed or reconstruct it so it's smooth, and then even suspend it with suture that absorbs. So, and we can do suspension even without reconstructing the ovary. So we think adhesions form in the first week. So if we suspend it, so it's not touching the ureter behind it, it can heal without sticking to that ureter. It'll fall back later and hopefully stay unstuck. So ovarian reconstruction or ovarian suspension with or without reconstruction. We do that. We used to use a lot of products made from amniotic membranes that helped promote tissue healing. I actually tried to get a patent for making an adhesion prevention product from amniotic membranes because I learned that, and this is kind of known, that they do surgery in utero. So they extract the baby from the pregnant uterus, do surgery like on the spine, put it back in. When the baby's born, there's no scar. So they've always said, there's got to be something in the amniotic fluid if it's done before 22 weeks. So I applied for a patent like 20 years ago and it was already taken, and now we have it. So that was good. We used that for the kind of last third of our 10-year study that has some tissue healing properties. But now even better, I think, and I think was a game changer for my wife, who again was very prone to adhesions and nothing else worked, what is PRP, platelet-rich plasma, which is your own blood that we collect when you're asleep, spin it down or centrifuge it to be left with the good part of the blood for tissue healing, the platelet-rich plasma, which they're calling liquid gold for its tissue healing properties. It's being used across specialties now, in ortho, spine, ENT, plastics, hair transplants, facials, dentistry, now coming to GYN. And I think it was a game changer for my wife, which is what got me back onto it. Really, nothing else worked. In her last surgery, there were no adhesions, when every other surgery had adhesion. In her second to last surgery, they used PRP.
Wow.
We also have Gore-Tex. We published a landmark study showing, it was the first study to show any adhesion prevention strategy and a benefit on pregnancy, which is actually easier to ask about than just doing a second surgery and counting adhesions. But it was the first time to show a doubling or a doubling benefit on pregnancy rates in patients with infertility and a cyst. Gore-Tex is what they make jackets out of. Nothing sticks to it. You can wrap the tube and the ovary in Gore-Tex, but it's another surgery to remove it. That's the downside. So I usually only talk about it in patients which had the study setting, which is infertility and a cyst. But also, to be honest, I'm using less of it now that we have the PRP. So we're going to use something, if not a combination of things, to really be deliberate about preventing adhesions. That is so important. That's the other half.
Yeah. It's funny you mentioned PRP because I've had back problems my whole life, and most recently that was something that was suggested to me was PRP, and I did not at this time go for it because it is it is very new and not covered by insurance quite yet, but at least in my scenario. But my mom actually had PRP in her shoulder. And she said with everything she had ever tried, that was the most successful thing. Like she has no pain in her shoulder at all. So it's really interesting and very cool that it's across specialties. So that's really significant.
Yeah. And ortho gave me that phrase, liquid gold. But my mother-in-law got it in her knee.
Mm-hmm.
And when we got it at one of the hospitals, all the staff is like, when are we all getting facials? It's all the rage.
Yeah. Yeah. So I'm curious to know, because you are so precise in not only the endometriosis removal, but also the adhesion prevention, how long does this surgery typically take you?
Well, we usually overestimate the time. That way we're not rushed and can do a good job. And I will, to be transparent, if it's a bowel case, so advanced endo that does or might require a bowel resection, which is, again, there's a thickness to it now. It's involving or kinking the bowel wall. The way to remove that is to cut out a whole segment of the bowel and to reattach it, which involves an inpatient hospital stay after surgery to wait for recovery of the bowel, for the bowel to work again. Those advanced endo cases that take a team, the way we do it is we allow all day for that surgery. The patient's the only case. We do one case all day. So I feel very blessed. There are some centers that are really focused on excision, but they don't have a good bowel surgeon to work with for the advanced cases. So this bowel surgeon I've worked with for over 10 years now, we do these bowel cases every Thursday, week in, week out. And I think over the years, he's done some of the most bowel endo cases in the country. And I like to joke, when you graduate residency, you get roasted. When he graduated residency, he got the OCD award. He may not be the fastest, but that's the guy you want for endo surgery. You have to be a little bit OCD to kind of pick it all out.
Right.
And so blessed to have him to work with. We learned from each other over the years, and our process is he's there from start to finish. So it's 2 surgeons, not just 1 surgeon, and 4 operating hands. So a question that's been asked is, why don't you use the robot? I've actually tried the robot, was credentialed on the robot, but it didn't help. The robot's not been shown to improve time or cost. Sorry, it's not been shown to improve outcomes in benign surgery. It's only been shown to increase time and cost. And it's more visible in patients. Increase time and increase cost. It's not been shown to improve outcomes. And they don't have the specialized laser that I use, which is a non-contact laser. I don't have to touch the tissue to cut the tissue. And that allows me to scallop it off or cut it off these really delicate areas, in particular bowel and fallopian tube. There's no other energy source I would use but this free beam laser, which is not available with the robot. So the robot doesn't really help. And interestingly, the bowel surgeon was telling me in some of the bowel surgery literature, like cholecystectomy, where you remove a gallbladder, it's been shown that 2 surgeons are better, safer than 1. So anyway, in our process for these advanced cases, there's 2 surgeons there the whole time, start to finish. And we have a hospital that allows us to be there all day, which for 1 case. Maybe this is too much, but to be transparent, when we first got there, they were like, why does it take so long? And why are all these patients coming from out of state for these surgeries? But they reviewed the cases and they found that, the patients did well and it was kind of worth it. So they actually gave us block time. The only other surgeon that get block time is a cancer doc and for GYN. So they really found that these cases, that they do well and it was worth it. So they allow us all day for one case. And that's huge. I would say to not be rushed is really helpful for outcomes and safety.
Yeah. Yeah. So now actually talking about outcomes, I know you said that the goal is a one and done surgery. It's not necessarily always promised, but that is the goal. For women that come into that surgery, maybe having experienced infertility in the past, or especially painful periods, since that is one of the number one symptoms, what is your experience, or what are the statistics of women still experiencing infertility or still experiencing painful periods after your surgery?
Well, I'll say the flip side. So we were part of a 5-center study, all centers that focus on endo. And our rate of finding endo was the highest, was over 80%. So, that's for all stages. So advanced stages, it's obvious. But even surface endo, sometimes, we have the largest series in teenagers on excision. In younger patients, it can be really subtle and hard to see or missed. So people have said, endo should only be treated in centers of expertise, because when it's advanced, it requires a team. If it's subtle, it still requires somebody to really be able to see it and remove it if it's over vital structures. Anyway, our rate of finding endo in this study was over 80%. I think it's even higher now. The rate of patients saying they feel better. So oftentimes people ask about pain, but sometimes, there's different types of pain that can be associated with endometriosis. Pain with periods, pain without periods, pain with intercourse, pain passing stool, pain passing urine. So sometimes some pain improves or some doesn't, and by different amounts. So we actually, and others have kind of recommended that we use more global features or measures of how is a patient doing, like quality of life and sexual function. So we're looking at those two global measures. 90% felt better, quality of life, significantly, and 90% felt better with sexual function. And then for fertility, it's up to 70% rate of fertility in 1 to 2 years. Now, the caveat there is you have to add to it the non-surgical optimization. So I always say our approach to fertility is to offer a comprehensive root cause treatment to increase one's chances. And that's, there's kind of two broad areas: the surgical or anatomy optimization, which is what I've decided to focus on. That's kind of my lane, to optimize the anatomy. But then there can be other non-surgical things that can need to be optimized in addition to or after surgery. In general, or to summarize, the hormones have to be timed properly to the cycle, targeted hormonal evaluation and support, improving cervical mucus and ovulation. So that's the non-surgical optimization. So when you optimize, and there's also the functional medicine piece, but when you optimize all those different areas, surgical and non-surgical, the pregnancy rates are up to 60 to 70% in 1 to 2 years, which is pretty good when you look at the rate of success for IVF is 32%.
Yeah.
And the patient's feeling better.
Right. That's exactly what I was...
And getting answered. And we strongly believe that wellness and fertility go hand in hand. Feeling better leads to better chances of fertility. And patients want answers. In our story, again, my wife was the first to say, to not get pregnant is bad enough, but to not be told why is insult to injury. And to be told you have unexplained infertility, we don't know why, you're not getting pregnant, but give us a bunch of money to just make the baby in the test tube. That's a slap in the face. It's actually much more accurate and truthful to say, yet diagnosed infertility, yet undiagnosed infertility, as opposed to unexplained infertility. If you look hard enough, you will almost always find a reason, and usually multiple things that can be optimized.
Yeah.
So again, I always say I just work here. My job is to optimize the anatomy, kind of set the table, and then offer it up. Surgery is humbling, fertility is humbling, but that's the part that we play to try to increase chance.
Yeah, that's beautiful. Do you require your patients to chart their cycles? Because you said, you're not only looking for the anatomy to be optimized, but you're also looking for hormones to be optimized. And that being able to track that on a chart, is that something that you require of your patients?
So again, I've decided to stay in my lane. I collaborate with, which is the surgery and the anatomy optimization, I call it. We collaborate with others on the wellness side and on the non-surgical fertility side. And usually they will require a patient is charting. Now, it doesn't have to be any particular system per se. They often, work with different types of fertility awareness, but it's very helpful to know where you are in the cycle to properly do what's called targeted hormonal evaluation and support.
Okay. Yeah. And I'm sure that both of those together is really, as you said, is really what's optimizing the whole woman, because you're not bypassing, you're not putting a Band-Aid, you are addressing the root problem, which is really the gift of what you are able to give to these women that experience endometriosis. Now, one of the last questions I wanted to ask you, there's a big debate that I've seen on whether endometriosis always requires surgery. What would your take on that be? I know, of course, you are a surgeon, but there are things you'll see on social media of maybe functional medicine doctors, naturopaths, where they are saying surgery is not always a requirement to heal endometriosis or heal the symptoms from endometriosis. What is your take on that?
I mean, I would love it if somebody put me out of a job. One day, maybe we'll discover some kind of a vaccine, or, we'll send in tiny robots to seek and destroy or something. But until that time, it does seem that it's a surgical disease, and best outcomes are achieved when you remove the disease. Again, we're removing the disease not just because somebody has endo. We're removing the disease to help symptoms, outcomes that matter to the patient. Feeling better, fertility, and maybe rates of repeat surgery. And all of those improve with surgery the most. I mean, if you have the worst case of endo and you can function, you're feeling fine, you can get pregnant, you don't have to remove it. Great. But people usually come to me because they've tried the Band-Aid, they've tried the bypass even therapy, which is the status quo, I call it, and it didn't work. So, I mean, there are things to help reduce inflammation. So again, we have a whole kind of a post-op resource list for people we collaborate with on the non-surgical optimization for fertility we just talked about, hormone cervical mucus ovulation, but also the wellness side, which has kind of two broad categories of nutrition and functional medicine. And those can be helpful in addition to or after removing the implants. But they usually don't replace removing the implants.
Okay.
I mean, you should try to justify surgery.
Mm-hmm.
But most have tried, and that's why they're seeking surgery.
Right. Okay, last question for you. And this is more of a personal curiosity, but my listeners know that about a little over a month ago, I had an ovarian wedge resection done from Dr. Erica Kreller, and she saw endometriosis as well, very minor, but she saw it, and so she removed it right then and there, again with the excision way. It was great. And so I'm curious to know, from my understanding, is that 50% around of PCOS patients also will have endometriosis. If you open up a woman and you see, of course, you're seeing endometriosis, you're removing that, but what if you also see polycystic ovaries? Are you trained in the ovarian wedge resection? Will you do that as well right then and there? Or is that something that you would refer off to someone else?
So I've decided to stay in my lane and do endo, but I will do endo plus whatever is needed while we're there for endo. So for example, for spotting and to help improve implantation, we look for and treat chronic endometritis. That's inflammation or infection of the uterine lining. We can open tubes if we need to. We can remove fibroids if we need to. We can do an isthmus seal repair if we need to, which is to sometimes if somebody's had a C-section, the way that muscle heals, a window is formed is too thin, and that has to be revised or smoothed out or something. Or PCOS, we can do the wedge resection. Yes, we do that. Not uncommonly. We're going to know that ahead of time. It's not going to be an accident. Again, with the mapping ultrasound, by the story, we can diagnose PCOS. We do measure the volumes, and we can plan ahead to say, do we think the patient would benefit from a wedge resection? I don't do it on everybody who has PCOS. I think it makes more sense to do it when the ovaries are big and bulky. The whole idea is to debulk the uterus so it works better. So we have that conversation, but that is planned ahead of time, and we can do that. Sure.
Gotcha. Dr. Patrick Yeung, thank you so much for your time and being on the podcast today. I know you are a busy man. For those that are interested in getting in touch with you, learning more about you, how can they find you?
The website is probably the best, restoreendo.com or restore-endo.com. The problem is there's not enough people to do this type of surgery. So we are trying to literally pay it forward and we're going to try to teach others and have a fellowship and things. So, there's just so much demand. I mean, if you call the office right now, there'd be an over a year waiting list. But if it was from one of your listeners or something, and somebody gave me a heads up, we get them in sooner.
Thank you for that. I also will say too, I know you just said your surgery schedule is over a year out. I was talking to one of my functional nutritionist friends who refers to you quite often, and she will tell her clients, it's a year out, but get on his surgery schedule, and then we have a whole year to optimize your hormones, optimize your nutrition, optimize your body to give you the best chance of surgical outcome. So just putting that out there too.
Yes, a personal referral, I would get them in sooner. But also, to your point, that's a great point. So there's a doctor who runs Facts About Fertility, Dr. Margaret Duane, MD for life in DC.
What a woman. Yep.
She's amazing. She's referred several patients to me, and it still boggles my mind, but she tells me it's true and has affirmed it several times that everybody she has sent to me has gotten pregnant. Praise the Lord, who's the ultimate healer. And within 6 months. Now, this is mind-boggling to me. Or at least it was a series of like 10 patients or so. And trying to kind of drill down why might that be happening. A potential explanation or contributing factor is that she's so good at optimizing the non-surgical factors ahead of time that you don't need that time after, and patients do better after the surgery when all the other non-surgical stuff has already been optimized. I do say sometimes the surgery can change things, or if the hormones are deficient, measure them again after surgery, they can be different. But maybe there's something there that the non-surgical optimization ahead of surgery might benefit or accelerate the outcome after surgery. That could very well be true.
Yeah. Good to know. Dr. Yeung, thank you so much for being on the show today.
Thank you so much.